maintenance therapy in AML is a topic that has been an area of active investigation for the last 20 to almost 30 years. And I think when we talk about maintenance therapies in AML, we have to consider the context. So one area that I would like to separate is maintenance therapy after allogeneic transplant from maintenance therapy after induction chemotherapy in patients who not proceed to allogeneic transplant eventually. So in a post-transplant space, there has been some progress in the last 2 years, especially with FLT3 inhibitors, namely Sorafenib. There have been two randomized trials published that compared treatment with Sorafenib for post-transplant maintenance in FLT3 mutated AML patients compared to observation in one trial and compared to placebo in the other. And both trials showed there was a survival benefit with maintenance therapy with Sorafenib. So that will probably become more frequently used in the future. But this is only applicable to patients with FLT3 mutations, which constitute a meaningful subset of patients, but most patients do not have a FLT3 mutation. And Sorafenib is also a medication that does come with some side effects, and there are other agents that are currently under active investigation, both FLT3 inhibitors as well as other genetically agnostic agents. And one of the areas that has been studied here is hypomethylating agents, both injectable Azacitidine as well as an oral formulation of ASA that's been known as CC486, or Onureg is the brand name. So this has been, injectable ASA has actually been tested in a randomized clinical trial as well in a post-transplant space, but unfortunately that clinical trial had been negative. So maintenance therapy with ASA post-transplant did not prolong relapse-free and overall survival. However, there were several limitations to that clinical trial, and other clinical trials in this space are still ongoing, for example, with venetoclax and azacitidine as well, and other targeted agents lend themselves as well to post-transplant maintenance therapy, for example, with IDH inhibitors. So that's for the post-transplant maintenance space, where we have the best data so far. In a post induction chemotherapy and consolidation therapy space, there's been really remarkable, potentially practice-changing trial that was presented by Andrew Way at ASH 2 years ago, and then subsequently published in New England Journal, that studied oral azacitidine for maintenance therapy in patients older than 55 who underwent induction chemotherapy plus or minus consolidation, and then were then not felt to be eligible for allogeneic transplant. And in this clinical trial, patients that received oral azacitidine maintenance therapy saw an overall survival benefit compared to patients who did not receive maintenance therapy. And the problem with this clinical trial is that it only is applicable to a small subset of patients that met the eligibility criteria for this for the QUAZAR AML-001 trial. So it will be interesting to see how how frequently this agent's actually getting used in routine clinical practice, and if there are specific patient subsets that are at higher risk of relapse, which may benefit more from that. And we saw a couple of updates presented by both Dr. Wei and Dr. Dörner at this ASH annual meeting, and they basically presented data with longer follow-up and in genetically defined subsets, namely NPM1 mutations and FLT3 mutations. And but we'll see where CC486 and oral ASA find its space.